Blocks account for almost, if I see 100 cases of infertility, almost 25 cases will have some tubal issues. Countries like India, which are developing, so the most common cause is infections. They don't have any symptoms, or when they don't feel like, they don't have fever, they don't have cough, they just neglect the tuberculosis. But generally, one family member, if they have tuberculosis, obviously there will be some form of transmission. Spreads retrospectively, from the vagina or the cervix. The infection spreads to the tubes, which blocks the tubes as well. Spreads retrospectively.
So when we say blocked tube, can it be unblocked? Yeah. What are the ways to unblock it?
So basically, this is how the tube will be appearing. Tube has 3 parts, technically speaking 4 parts. This is where the tube gets attached to the uterus. This middle part is where the fertilization occurs. The egg from here and sperm from vagina comes, and there they form the embryo. And this is where you see some fimbrial ends or like some hands. These are nothing but to catch the egg. So basically, take it as 3 parts. The tube has 3 parts. So what happens is, when the block, you have some tests to diagnose the block. I'll just give a brief idea of it. So basically, you have tests called HSG, SSG, all those things. HSG is nothing but it's called hysterosalpingogram. You do this test on day 7 of cycle to day 12. In this vagina, you just inject a dye or some form of liquid, and you just see the spill. That dye should come through both the tubes. So you call it as HSG, hysterosalpingogram. With this test, you will diagnose the point of block. Whether it is here in the starting point or middle or at the and where the block is. You have some other tests called SSG, saline salpingogram, where you inject some saline into the vagina and check for the spill on the ultrasound, which we do it on a monthly basis. And third one is obviously when you have to confirm the block, or the gold standard of diagnosing the block is always laparoscopy. So generally what happens is, on HSG or some SSG, you feel the block is at proximal or here, proximal tubal blockage, which means the block is somewhere here, where the tube is attached to the uterus. At that time, you can go for a procedure called hysteroscopic tubal cannulation. Okay. So what we do generally in that procedure is we just insert a small camera through the vagina into the cervix, into the uterus. It's called hysteroscope. So you just keep a small camera, and you will have a soft cannula or a small, very thin, soft tube. So you pass this tube to the hysteroscope, try to negotiate this block, try to clear that block. If they are little slender, tiny blocks, they'll get cleared. If they are very hard, then they might need some manipulation. When the same block is somewhere in the middle, then the procedure becomes little difficult, because you need to pass the tube all the way from here to here. The tubes are very slender. The more you manipulate, the more damage you will create to the tube. So always when the tubal block is somewhere in the middle, then your procedure will get little difficult, and the chances of clearing the tube is also difficult. So generally, whenever you get a patient with some block in the mid part or something, we always counsel them like it might be successful or might not be successful. So generally, that's how you clear the tube, and then you inject a dye, and you also keep a laparoscope in the stomach from the above, and look through the laparoscope whether the dye is passing after clearing the block or not. So this is generally a simple procedure. It takes around 25 minutes or 30 minutes time. We don't do it on OP basis. Hysteroscopic cannulations or laparoscopy, we give anesthesia. The patient comes in the morning and goes by the evening. So basically, when the blocks are proximal, the chances of clearing are little better, but middle blocks are little difficult. Sometimes they'll have slender part getting blocked. Then you have a procedure called fimbrioscopy, where you pass the cannula from the above, from the abdomen, and try to clear the block. Then those chances are very less, of clearing the block. So always we explain to the patient about the positive and negative impact of the surgery. So, and then proceed to the clearing of the block.
So the proximity of the blockage to the uterus defines the ease or the difficulty level of clearing the blockages.
Yes, 100%, 100%. So that's how generally we proceed to our patients, like tubal blocks and clearing them. So patients will come to us saying, why can't we clear these and all? But tubes are very slender. You have some hair-like things in the tube called cilia. Any hard manipulation or hard instrumentation in the tube will damage the tube permanently. The tubes are one of the finest parts in female reproductive system, which should be dealt with a lot of slender care.
Do we use foam to do SHG test in India, or is it just dye that we use?
No. You have something called hycosi, where you can inject some form of soap bubbles or foam to look for the spill in both the tubes. But in our country, basically nowadays those dye and all are not available readily because they have documented some form of reactions and all those things. Nowadays they are not readily available, so they do HSG.
What is the best course of treatment for somebody with blocked tube or damaged tube?
So always when you diagnose the tubal block, always find out the point of the block, whether it is proximal, middle, or distal. Where exactly is the tubal block? Is it unilateral? I mean, is it just one side or is it both the sides? Confirm the proper block site, and then we should counsel the patient accordingly. So generally how I proceed is when there is proximal tubal block, always I counsel them, there is a chance of going for the surgery. We can cannulate the tube and try to go ahead. But only even some studies say, even if you clear the block, you should have the result within 6 to 8 months, or else the infection reoccurs or the thickening of the tube reoccurs. So you should plan for pregnancy as early as possible, even if we clear the proximal tubal blocks. So that is one of the catch point here. And when the same tubal block is in the middle, so basically I counsel them when the block is hard or when it is totally thickened, the chances of success are less. Then generally I counsel them for IVF as well. So basically the reason for me counseling for IVF is instead of going for this procedure where they have to spend little money, I always tell them go for some other procedure where you will get a better result instead of going for this. So always it depends on the location of the block. And sometimes people come to me, I evaluate the male partner thoroughly as well. What happens with the male partner semen analysis count is very less. For example, if it is less than 5 million or 6 million, there is no point in me clearing the tube and asking them to get pregnant. Practically impossible. Maybe 1 in 100 gets pregnant. But then once I evaluate the male partner and his count is very less than 5 million or 4 million, then I directly advise them IVF instead of going for this procedure, trying naturally. That kills their time more. Always my advice is always evaluate the male partner before attempting any surgery on the tube. And if you feel the male partner's parameters are not good and it is a clear-cut indication for some ART procedure like ICSI or IVF, instead don't perform this tubal clearage procedure.
Yes.
Women with blocks, it's not life-threatening. Nothing much will happen. So instead advise them something which is better. Considering her male partner.
Yeah, because we are result oriented as a fertility.
Yeah. Basically, when your counseling is genuine and clear, patients will accept whatever you feel it's better.
And I'm so glad you're doing that, because it looks like a lot of male patients do not come readily for tests or treatment.
Yes, but there is no other option. I treat a tubal block and then the male partner comes with 1 million count or something. What's the point in wasting her time and wasting her money?
So true, so true.